Basic airway management. Airway management involves assessing the passage of air through the respiratory system. The major structures air passes through prior to ventilation occurring are the upper airways consisting of the mouth and nose, the pharynx and the larynx, and the lower airways consisting of the trachea, the bronchi and the bronchial tree, and the bronchioles and alveoli. The objective of effective airway management are to ensure the airway is patent, ensure the lungs are adequately ventilated, and to protect the lungs from the aspiration of stomach contents. Airway management is required when a patient is not able to maintain their own airway adequately or is unable to self-ventilate adequately. This may be due to a decreased level of consciousness. Generally, a patient with a GCS less than 9 is unable to maintain their own airway, an obstructed airway due to swelling or foreign body obstruction, or respiratory failure. Airway management begins with an assessment of the airway. To perform a rapid assessment of a patient's airway, we look, listen, and feel. We look for rise and fall of the chest wall. We listen for the presence of breath sounds or the presence of abnormal breath sounds that may indicate an airway obstruction, such as grunting or stridor, and we feel for air movement from the patient's mouth. If the patient has no chest wall movement, no breath sounds, and no air movement, this is a medical emergency and immediately help is required. If the patient is observed to have chest wall movement, breath sounds, and air movement, it is important to continue the airway assessment by auscultating the lungs. Auscultating the lungs allows you to assess air entry into the lungs and observe breath sounds. To auscultate the lungs, listen to the right upper quadrant, the left upper quadrant, the right lower quadrant, then the left lower quadrant. This allows you to assess air entry into the right lung fields versus the left lung fields, and air entry into the apices versus the bases of the lungs. It also allows you to observe for the presence of abnormal breath sounds, which indicate an issue with the patient's airway patency or ventilation, such as stridor, wheeze, and crackles. Abnormal breath sounds. Stridor is one of the more common abnormal breath sounds that indicate an airway problem. Stridor is a high-pitched musical sound most commonly heard on inspiration. It is generally caused by an obstruction in the upper airways by laryngeal edema or a foreign body obstruction. Because stridor is due to swelling in the upper airways, it is generally only heard in non-intubated patients, as airflow bypasses the upper airways when an ETT is in situ. Listen to what stridor sounds like. Wheeze is another abnormal breath sound that may indicate an airway problem. Wheezing sounds like a continuous, hoarse, whistling sound. It is most commonly produced during expiration, but may also be heard during inspiration. It occurs when air moves through narrowed or obstructed bronchial tubes. Listen to what wheeze sounds like. It may be caused by bronchospasm, asthma, COPD, inflammation, or a foreign body obstruction. If the patient is showing any signs of airway obstruction, call for help early. There are some simple measures that can be used to improve the patient's airway until help arrives. The simple measures to improve airway patency include airway maneuvers, airway adjuncts, and an advanced airway. Basic airway maneuvers are simple but effective techniques that can be used to optimize airway patency for a patient with an obstructed airway without the need for equipment. Airway maneuvers improve airway patency by lifting the tongue and pharyngeal tissues anteriorly. To perform a head tilt, place a hand firmly on the forehead and tilt the head backwards. To perform a head tilt chin lift, tilt the head backwards and lift the chin by placing the fingers of the other hand under the bony part of the lower jaw, lifting the jaw forward. To complete the triple maneuver, extend the head backward and use the fingers of both hands to grasp the ramus of the mandible, which is then displaced forward and upwards. Then use your thumb to open the lower lips. Airway adjuncts can be used to improve airway patency by preventing the soft tissue from obstructing the patient's airway. There are two main types of airway adjuncts used in the intensive care unit: nasopharyngeal airways and Guedel's airways. Both airways can improve airway patency by preventing soft tissues from obstructing the airway. Let's go through some case studies. Case study 1. Your patient who was extubated 2 hours ago has become increasingly drowsy. Their GCS, which was 15, is now 12, and you have asked the ICU team to urgently review the patient. The patient's oxygen saturations are 98%, but their breathing has become noisy. What airway adjunct would you consider for this patient? So the answer is a nasopharyngeal airway, or an NPA. Why? The patient is not unconscious. Therefore, an oropharyngeal airway would likely cause coughing and gagging and place the patient at risk of aspiration. So how do you select the correct size NPA, and how do you insert the NPA? Nasopharyngeal airways come in a variety of sizes. To choose the appropriate size for your patient, place the naropharyngeal airway next to the patient's face. The airway that reaches from the tip of the earlobe to the tip of the patient's nose is the correct size for the patient. It is also important to ensure that the diameter of the nasopharyngeal airway is not larger than the patient's nostril. To insert the nasopharyngeal airway, lubricate the airway, then point the bevel towards the septum and advance. Once in place, secure a safety pin to the nasopharyngeal airway to prevent the entire airway adjunct from slipping into the patient's nose. If there is a lot of resistance while inserting the airway adjunct, remove the airway and try the other nostril. Complications associated with the use of a nasopharyngeal airway include epistaxis, aspiration, and esophageal placement. So let's continue with the same case study. You insert the nasopharyngeal airway and the patient's breathing becomes less noisy. However, after a few minutes, the patient becomes unresponsive and their oxygen saturations have dropped to 88%. What alternative airway adjunct might you consider using until help arrives? So the answer is an oropharyngeal or Guedel's airway. The patient is unresponsive and now more likely to tolerate a Guedel's airway. A Guedel's airway will also provide better airway patency than a nasopharyngeal airway. So how do we measure an oropharyngeal airway and how do we insert it? Guedel's airways also come in a variety of sizes. To choose the appropriate size for your patient, place a Guedel's airway next to the patient's face. The airway that reaches from the tip of the earlobe to the corner of the patient's mouth is the correct size for the patient. To insert a Guedel's airway, insert it with the concavity facing the palate, advance the airway and then rotate it 180 degrees. Complications associated with a Guedel's airway include mucosal trauma, worsening obstruction, and aspiration. So to continue with the case study, the ICU team arrives, and despite the use of appropriate airway adjuncts, the patient has now become apneic with oxygen saturations of 84%. What would be the next step to improve the patient's ventilation? The answer is provide bag mask ventilation. Bag mask ventilation uses a face mask and a self-inflating bag with a reservoir bag to provide positive pressure ventilation. It is often referred to as bagging the patient. The most important things to remember are: ensure you have a good seal of the mask against the patient's face. This is much easier if you have two people, one to hold the mask onto the face and one to manipulate the bag. Observe the patient for chest movement to ensure you are not ventilating the stomach. Ensure you don't squeeze the bag too hard and cause the overdistension of the lungs. A self-inflating bag can deliver a tidal volume up to 2 litres, when most patients only require 3 to 500 mils. Aim for a respiratory rate of 10 to 16, so about 1 breath every 4 to 6 seconds. So to continue with our case study, the patient's oxygen saturations have improved to 99% with the use of a Guedel's airway and bag mask ventilation. However, the patient remains apneic. What would be the next step to manage the patient's airway and improve their ventilation? So the answer is insert an advanced airway. The indications for an advanced airway include an unconscious apneic patient, a patient with respiratory failure, a patient with an acute upper airway obstruction, a patient who requires frequent tracheal suctioning, or a patient who requires airway protection to prevent aspiration. The standard airway management for a patient requiring an advanced airway is a rapid sequence intubation, known as RSI. RSA is an advanced airway technique that involves the prompt induction of unresponsiveness and muscle relaxation to render a patient unconscious and flaccid in order to facilitate rapid intubation of the trachea. Intubation involves a number of steps. Preparation is key. This involves preparation of the equipment required to intubate the patient and preparation of a plan for the intubation, including clarifying roles. Pre-oxygenation is generally required for at least 5 minutes using bag mask ventilation. Pre-treatment is required and involves administering sedative medications and analgesia. Paralysis with induction is required. This involves the administration of neuromuscular blockage agents such as vecuronium, rocuronium, or dexamethasone to immediately prior to intubation. Protection, cricoid pressure and positioning. This involves the application of cricoid pressure immediately after the administration of paralysis agents and placing the patient in the sniffing position. Placement and confirmation of placement. This involves intubation of the trachea with an ETT and confirmation of correct placement with end-tidal CO2 monitoring and auscultation of the chest. Post-intubation management. This involves applying tapes to the ETT to secure it, performing a chest X-ray and a blood gas. So what equipment will you need to intubate your patient? A lot. So you need a laryngoscope for visual view of the larynx for tube insertion, a stylet, a stethoscope for listening to the chest to confirm placement, lubricating jelly for lubricating the tube, a 10 ml syringe for inflation of the balloon, a Yanker sucker to remove sputum from the airway, McGill's forceps, a bougie, drugs, end-tidal CO2 monitoring, and a ventilator. Applying cricoid pressure. Applying cricoid pressure minimises the risk of the patient aspirating their stomach contents during intubation. So how do you locate the cricoid cartilage? So locate the thyroid cartilage, or the Adam's apple, and move your fingers down in the midline towards the chest. Below the thyroid cartilage, you will feel a soft area, the cricothyroid membrane, and then another cartilage. This is the cricoid cartilage. So how do you apply cricoid pressure? Once you have located the cricoid cartilage, place your index finger over the cartilage and then place your thumb and middle finger on either side and apply moderate pressure. Do not release the pressure until correct placement of the ETT has been confirmed, the cuff has been inflated, and the doctor intubating the patient advises you to release the pressure. So what is required in the care of the patient post-intubation? As the nurse caring for the patient, is it important to provide post-intubation care, and this involves performing a patient assessment using the ABCD approach, measuring the cuff pressure using an anemometer to ensure it's at the correct pressure, checking the tapes to ensure the tube is secure in the patient's airway, documenting the position of the ETT at the teeth in the patient's notes or in their care plan, ordering a chest X-ray to confirm appropriate tube placement, and perform an ABG to assess ventilation and oxygenation. Start sedation for ETT tolerance and patient comfort. Inform the patient, if they're conscious, and their family of the need for intubation, and restock the intubation trolley and any other equipment you've used. So some key points. If you are concerned about your patient's airway patency or ventilation, call for help early. Understand the basic airway maneuvers and airway adjuncts that you can use to manage an obstructed airway, and understand the process of RSI and your responsibilities as the RN caring for the patient. Thank you.